Hey, everybody. Welcome back to the You're Not Broken podcast. I have on my good friend, Dr. Corinne Menn. And here's the cool thing about this is you were on my podcast before talking about hormones after breast cancer. So people need to go dig that one up. I'll try to, I didn't remember what episode that was, but it was a while ago. Welcome back.
Thank you for having me.
We're excited today because we are going to nerd out about a paper that just came out by Sasha Taylor and Susan Davis called "Is It Time to Revisit the Recommendations for Initiation of Menopausal Hormone Therapy?" And we both got very excited and we both printed it out and we both highlighted it in green highlighters.
We didn't plan that.
We didn't even plan it. But you were on a text thread. You were like, we need to talk about this because it's time. Why is it so timely to talk about the age of initiation of hormone therapy?
Well, because millions of women feel like they've been missed out. And I use something in my slide presentations when I talk about hormone therapy and the data and the evidence and guidelines. Boomers should be pissed. That's from you, Kelly, because they are pissed because they're like, hey, wait, now I'm 65 or 70 or, more than 10 years. And my doctor says, too bad, the window's shut. You're out of the window. I can't help you. And with the menopause movement happening and more information, all of us are getting, questions from our patients who are past that ideal 10-year window, which we all agree on. Like, we love the 10-year window, but it doesn't slam shut. But there's really a lack of published guidance and people's, putting their viewpoint out there and citing the data in ways that really inform doctors on prescribing outside of that window. So that's what got us excited about this excellent viewpoint.
Excellent viewpoint. There's so much I want to talk about, but correct me if I'm wrong, age 60 or greater than 10 years post-menopause, which are the two cited, window closing dates, it's arbitrary. There's nothing magical about one day after, one day before, it being 9 years, it being 11 years. It is arbitrarily made up. Can you explain why we picked that? Or again, it's arbitrary, but why is there two different age groups on risk benefits?
Yeah. And I always want to remind people, it's not age 60, right? It really should be thought of this ideal window is starting from when you enter menopause. So, many women, 53, 54, so their window extends. So that's number one. But it's because of the data as we all kind of generally understand it, right? Is that if we initiate hormone therapy earlier on, particularly for cardiovascular and likely for dementia, brain health, that we are going to get more bang for the buck, so to speak. We started earlier before we have disease progression, right? And that's been supported by countless studies that we've talked about, right? And so I think that, along with kind of misinterpreted and overstated fears of risk, which we'll get into, has just led to this very reductionist view. And it's put these capstones on when you can or can't, which is nonsense. Like you said, it's a spectrum. And patient choice really needs to come into play here. And also this understanding that symptoms are more than just hot flashes for 2 years. And also we've lost sight of the long-term benefits of hormone therapy on bones, something that we have FDA approval for decades on, right? And so those are all the reasons why this is huge.
I love that. And I also think, 1/3 of women they'll have a hysterectomy, they'll have a uterine ablation. They don't actually know when their last period was, right? Yes. So it's kind of just to add to the complexity of this is kind of a made up number, because a lot of women are like, what am I supposed to do? And they kind of get fixated on not knowing when menopause was. But I think, let's talk about what the timing hypothesis is and kind of where the timing hypothesis came from as why there is that kind of arbitrary age cutoff.
Yeah. And the timing hypothesis, I think, is, it's an important thing. And as we move forward and have more women and doctors educated about hormone therapy, hopefully, in the future, we won't even have to worry about this because women will have access early on, right? But that's not where we are right now. we're in a place where there's this rush of, awareness and information leading all of these women, really kind of left high and dry. And the doctors are, most doctors don't even know how to prescribe hormone therapy to the average woman, right?
To the perfect candidate.
The perfect Barbie, like I said,
The
versus
Barbie,
the
the
weird
perfect Barbie.
Yeah, versus the weird Barbie who doesn't fit all of the, within the first 10 years, and she has a normal BMI and she has no coexisting, medical issues. But most women aren't that.
Yeah.
And really, I mean, I think it's probably one of the biggest problems that, menopause specialists and general OBGYNs do, because even if they get themselves comfortable with, the basics of hormone therapy, once we have someone outside of that window, and the window hypothesis, Dr. Hodis, which I know you've talked about, his incredible paper where he did an extensive review on the cardiovascular, impacts of initiating hormone therapy early versus late, really showed it so beautifully how you can halt progression of endothelial changes, progressing atherosclerosis, calcifications in the arteries. And that, if you initiate it later, it doesn't appear to be worsening it, but it's not going to prevent what's already happened, right? So that's really the timing hypothesis. And in terms of the brain health, I always like to tell women, simply put, heart health is brain health, right? So if we start things earlier and you're doing all the good things for, heart health, exercise, diet, but also considering adding hormone therapy, that's going to benefit your brain. And if you wait till way later, we can't reverse microvascular changes. So,
Yeah.
I mean,
there's so many takeaways. I think the biggest one that for people to realize is the Women's Health Initiative was oral medications which increased clotting factors and had a synthetic progestin. We do not, by standard, use those medications anymore, and the transdermal route and the natural progesterone don't increase clotting risk, don't increase heart disease, and they're incredibly safe. So to take a big study that a lot of it's been debunked with medications we don't use and to continue to apply it to those boomers and those people who are older is not good medicine. And I love that this paper came out because we've got this massive documentary on PBS coming out now, and all these women are going to say, what about me? And I just think it's so timely that this paper came out.
Yes. And in the paper, the authors make that very point, that the women in the WHI were on whole less healthy, older, average age, I think about 63, more of them had, pre-existing heart, hypertension, other issues. And so I always like to say, like, given the worst case scenario, right, of a patient population kind of, right. So we had an older, slightly less healthier population, and we gave them oral and synthetic progestin, progesterone acetate, which we tend to not give as much anymore. Not that it's all bad. So given the worst case scenario, we actually have really good data.
Yeah.
And no one wants
given how unhealthy these women were, even on worst case scenario of oral medications and synthetic progestins, they did very well.
Yeah, so everything we'll talk about from what this viewpoint, is discussing is they're coming from a place of using worst case scenario, and in that case, it's pretty darn good, right? And then they take it up a notch and say, and hey, if we would then take a next step further and then use, like our FDA approved bioidentical hormones and progesterone and estradiol and a transdermal, and we take those approaches, then we're going to have even better results. So we really need to be a lot more nuanced and less black and white about this initiation window, right? So that's huge.
I love it. Yeah, I mean, I think so many women will say, my doctor said I can't after age 60, or I can't after about, like, it's a very black and white. And so I'm like, let me go back to the 2022 North American Menopause Guidelines and find where they say it's a iron curtain. And they don't say that. They don't say it at all. But this is what they say in the abstract, and I want to read it and how easily this gets misinterpreted. I think the guidelines are lovely, but it gets misinterpreted. It says, for women who initiate hormone therapy more than 10 years from menopause onset or who are aged older than 60 years, the benefit risk ratio appears less favorable because of the greater absolute risk of coronary heart disease, stroke, venous thromboembolism, and dementia. Now, two things that I want to bring up about that sentence. Less favorable if you don't clarify what less favorable means, it's incredibly nebulous. Could sound way worse than it is, but it's actually not so much less favorable. It's just not as good as if you start it early. And then in addition, this statement is from the WHI, which again, oral, which increases clotting factors. And as the WHI kept going, that risk for heart disease, stroke, and clot, it really, really started to decrease or become not significant. So I think we're using, again, even in this position statement, we're using old data to put an absolute iron curtain on these older women.
Yes, and true in the statement, it isn't an iron curtain. They don't say no, right? And these are guidelines, right? They're not absolute rules. They're just there to give you a framework, right? The problem is most doctors don't have time or never informed on how to really understand the nuances of the framework. So this paper is a great viewpoint, and really it's not a new study. It's literally looking at the data that's been there
reanalysis
for decades and literally restating what is actually in the data. So slightly frustrating because it's been there all this time. But you know what?
I mean, it really takes that academic person who has the time and has the resources of statistical analyses to break down these old papers. So, that's why I love reporting the news and not researching the news, because it's like, dude, you have to dig. You have to find the follow-up studies. And at the end of the day, this is going to benefit millions of women, though. It's huge.
We can't treat women based on a headline. And, just getting to, I want to read, there's so many good little pearls in here that I highlighted in my green highlighter.
Bring it.
One thing that I wanted to kind of just point out is, you said, well, why is this important? And we said, well, because women are banging on our doors asking, what about me? Right? So, yes, that's important. But, here they speak that, we know that the average length of vasomotor symptoms, hot flashes, night sweats, and we know it's not just that, but I like to kind of say that and everything that goes with it, right? 7.4 years. But they go on to say, it's 9 to 10 years for African American and Hispanic women, with about 40% of all women having some sort of vasomotor symptoms for at least 14 years. And then similarly, we found vasomotor symptoms affect 42% of women aged 60 to 65, being moderately to severely bothersome for over, close to 7% of women at this year, and many persist in 1/3 of women beyond age 65. So this is just saying, this is not just like a little hump to get over. They're citing that, at 14 years, 40% of women will still be reporting these symptoms, right?
Dude, I had lunch with a reporter about the documentary coming out. She was in her 60s, and she's like, I just sailed through menopause. I've had no issues whatsoever. And I know enough now to not believe anybody, because they just don't know the shit that's happening is because of menopause, right? And so I'm like, okay. And in my head, I'm like, wait for it, right? And later in the conversation, she's like, I haven't slept well in years. and I'm like, there it is. People don't even know it. Like, what they're experiencing is because of, low hormones.
Well, yes, because the FDA approval for hormone therapy is for moderate to severe vasomotor symptoms. So people think, well, that's what menopause is. And frankly, we both know that there are women who get over kind of the hump of the worst hot flashes. And then there's the longer term kind of chronic things, the sleep disturbances, the joint pain. I mean, we know the list goes on, mood changes, sexual effects. And so we do need to move beyond just the hot flash. But it was just great that they pointed out that even if we're just talking about hot flashes, we have a huge proportion of older women who are still suffering with that, which we know has many downstream effects on sleep, mood, daytime alertness, cognition, all of that.
Yep.
And so I thought that was like a startling good point, right?
Yep.
And I love that the viewpoint explores the evidence relating to the risks and benefits of initiating this after 60 years, with the aim of stimulating discussion regarding the need to review current recommendations based on age or years since menopause. And I know you and I and many others out there have been talking about this. We need to push this conversation, right? Because if we're going to just sit here and wait, it's not going to happen.
No, too many people are going to die and suffer.
just suffer.
I love this is they're saying the WHI clinical trial data do not support adverse effects in older women for the primary outcomes of coronary heart disease, which included non-fatal MI and cardiovascular death. Like even the WHI, when they stratify it out by age, this is a pretty damn safe medication, and we use even safer medications now.
Yes, and
one
so
of the
that's
things, like I wanted to ask you what you've seen, because to me, I'm like, women say I can't start it because I have high blood pressure. About a third of the people in the WHI had high blood pressure, right? Like
yes.
high blood pressure is not a contraindication. It's an opportunity to talk about are you exercising? How are you eating? How's your stress? Sometimes going on hormones, some people, their blood pressure gets lower.
Yeah, totally. So super
it's not
important.
a contraindication to have high blood pressure as a reason to not start hormones.
No, nor is high cholesterol, nor is a family history of breast cancer,
Nor
or
is smoking. I mean, to me, I'm like, let's work on stopping smoking. That's a modifiable risk factor. But it says in this paper about a third of WHI participants were smokers.
yes. So again, worst case scenario situation, and then they go on to quote how really relatively quite safe it was even in the older population. And I think you just kind of quoted from the one, paragraph where they said overall the WHI data suggests that the initiation after age 60 or older than, 10 years does not increase cardiovascular disease mortality or all cause mortality. Right.
Mm-hmm.
And what's really great is, they go on with this, like, I'm sure did you highlight this chart? Where they looked at all the specific things, because, cardiovascular disease is kind of like a big tent. So
Yep.
women ask us all the time, well, what about stroke? What about heart attack? What about pulmonary embolus? And, this paper goes through all of these things. And I think this is important. We should talk about, will you explain like the difference to the audience between the intervention phase versus the 13-year cumulative follow-up? Because this paper looked at the difference between the data that was initially, pointed out, but then the WHI did follow these people, right? Mm-hmm. For many years, right? There's been multiple follow-ups, and they're looking at specifically the 13-year follow-up data. And for coronary heart disease, for heart attacks, for stroke, and for pulmonary embolus, there's a little blip that in the first, when we first initiate this oral synthetic hormone therapy, there's a small, tiny blip, still considered very rare in pulmonary embolus. But for all the other things, there was no difference, even in women who were 60 to 69, and then in the other cohort, 70 to 79 years.
I'm going to point out some gender bias because it's always fun, because I'm a urologist and I take care of the men. So the Traverse study just came out. This is looking at sick men, known cardiovascular disease. So you had to have had a heart attack or a diagnosis of cardiovascular disease before entering the trial. It was testosterone versus placebo. The results say it's very safe. They do very well. It didn't make much worse, but it did have an increased risk in pulmonary embolism compared to placebo. Nobody talks about it because it's teeny. The risk is the pulmonary embolisms are very rare. And even a statistically significant increase is still very, very rare. So when you take a man and his hormones, you're like, overall, even the sick guys did great. Testosterone's safe is the memo. Yeah. Slightly smaller. But we don't take testosterone away from millions of men because of a, single to double digit increase in a very rare thing. And the way we think about women is different.
Yes.
Like nobody can have this because somebody got a PE once. Like that's not fair.
And these risks cited here are very, very similar to the risks of the oral birth control pill in younger women, right? Like very tiny risks. We know oral birth control pills, even in a young woman, it's very rare, but it can happen, right? You can have a blood clot. It happens. But I don't know any OBGYN who's afraid to give a birth control pill. And we give it to millions of women, and we've done it for decades, right? Without fear. But when it comes to talking about quality of life, health span, all these things for an older woman, suddenly it's controversial. And I like that you pointed out the rare. And so they made a point in this to point this out. And I think a lot of doctors don't even understand. So, like, the absolute risks of any of kind of concerning things, stroke, blood clots, are considered extremely rare, right? So anything like less than 10 per 10,000, right? These are really tiny numbers. And it says like the Council of International Organization of Medical Science would classify that as something extremely rare and uncommon. But yet
Yeah.
we make it a headline.
I think that's important because we've actually quantified what risks are, right? And one thing is statins have a very rare increased risk of breast cancer. But it's classified under the very extremely rare, right? Like it's there, it came out in the data, but it's super rare, so nobody talks about it because we're like, hey, the benefit outweighs this very rare risk. And
Yes.
to think that menopause hormone therapy is somehow this unique medication that alone has, risks that make it like the risk of falling and having a bleed on blood thinners is not very rare. But people are on the medication because it benefits them, right?
Yes.
And so I just think, the conversation of risk benefit is nuanced and it takes a while to have that conversation. Medicine's not black and white. But as far as medications go, hormones, of which your body naturally produced, are some of the safest medications that we can take.
Yes. And, there's so many pearls in here that even in these older women, the cardiac events, the stroke, heart attack, they were either not at all different between them and the younger women, or if they were so extremely rare that the authors make the point that we have missed the big picture, that they're not being weighed against the incredibly important. They really double down on this importance of, women losing out on fracture protection and protection against osteoporosis, which I think you quoted the other day, right? 1 in 2. I'm
One
sure
in
it's safe.
two. I had to go look up that statistic when I quoted it because I was like, but I read it in one of these papers and I was like 1 in 2, and I'm like, that sounds really high. So I looked it up and I'm like, oh shit.
Yeah.
It's very high. So let's talk about dementia. Because one of the biggest reasons that I hear people is like, number one, their age, which we now know is made up. And I always tell women this, like, a 60-year-old is not a 60-year-old is not a 60-year-old. Have you been to your last high school reunion? Like, you guys all kind of look the same when you were 18, but we are aging at different rates, my friends.
Yeah.
So like,
yeah.
So age is not like it's kind of like saying how healthy you are by BMI is like, it's a very fuzzy kind of okay metric, but not the best we can do at this point. But so age, but then number 2 is dementia. And so they're talking about when you take the WHI data and you again put the long lens of how do these people do. First of all, conjugated equine estrogen alone, meaning no medroxyprogesterone acetate, there was no adverse effect on any cognitive anything. WTF, how much estrogen have we held from women because we said it caused dementia? Like, that's like second to breast cancer scare, I think. Again, like proven not to be true.
So important. Estrogen alone, conjugated equine, oral estrogen, just like the breast cancer data. It's the same thing. In both cases, there was no problem. And in this paper, it points out, regardless of age of initiation.
Yeah.
Right?
I feel like estrogen just like can't help itself from getting such a bad reputation when really it's like the medroxyprogesterone acetate, which is like the dick in the corner, like doing all the harm. And people are like, she's like the whipping boy for medroxyprogesterone acetate. But so, I mean, the other thing is, let's look at the combo. Let's look at again, these are meds we don't use, but let's see how bad it is, right? So slightly worst case scenario, oral conjugated equine estrogen plus medroxyprogesterone acetate in the WHI, which we don't even use these meds anymore. Increased risk of dementia, 23 extra cases per 10,000 women. Mild cognitive impairment was not affected, and death from dementia was not affected.
And this, Kelly, this is in women over age 65. Okay.
Yeah.
So we're everything we're talking about is we already know the window of opportunity, the younger women.
Yeah, we know the young ones, you're fine.
We are we are doubling down. We are talking about the older women, right? And then and so yes, 23 extra cases for 10,000 women. And like you said, no significant change in cognitive. And then they go one step further because what do we really care about, right? We care about Alzheimer's deaths, right? So you would think that this perhaps slightly increased risk of dementia in the combined in older women was going to then equate to greater mortality from dementia over a decade later. And I just have to read it exactly so that people are very clear. All right. However, at the cumulative 18-year follow-up, this combination of medroxyprogesterone, acetate, and estrogen, right? This combination was not associated with death from Alzheimer's disease or other dementia in older women. Conjugate equine estrogen alone was not associated with dementia-related death in women aged 60 to 69 at randomization. But for those aged 70 to 79 years at assignment, the risk of death from Alzheimer's disease or other dementia was significantly reduced.
Mic
Okay.
drop.
So
Mic
what,
drop. Dude, the
what's,
boomers need to be pissed. Boomers,
they're
if you're not
totally,
fucking pissed yet, I don't know. You're not paying attention.
and so listen,
This
I
is
will
why they're
still,
withholding hormones from you.
yeah,
Because
this
it
is why.
reduced your risks of dying from dementia.
So, and you know what? The authors, will always come back and go on, we know that we are going to 9 times out of 10 choose a transdermal estrogen option. When we can, we're going to use progesterone. If you don't have a uterus, you could just do estrogen alone. And they go on to say that probably prudent and based on the data, particularly in older women, start with the lower dose and then, titrate to meet the needs of your symptoms. But I think that's really important. And I think that this idea that we are completely dropping the ball on bone health and fracture risk, which has far greater impact on women. And it's just not talked about enough. And
and how many women within the 10-year period, so the younger ones, are withheld these medications because of the fear of it happening when you're older or starting when you're older, right? Which we now know even they did really, really well.
Yeah. And so women ask me all the time, like, okay, so Dr. Menn, I don't have a ton of symptoms anymore, although I'm always like, really, let's go through the whole symptom list. But fine, they don't have a ton of symptoms, but they're really concerned about their bone health. But they're 65. And they're like, okay, I'm 65. I've got osteopenia. I don't have a ton of hot flashes. I'm kind of over that hump. But my doctor says at this point, I'm too old to use it for bone health. And which is crazy because this is one area in older women that we actually have really good data that in older women, more than 10 years from their last period or menopause, the data shows that even the smallest doses of estrogen can be incredibly protective. And they don't even need very large doses. In fact, it's actually the opposite. The younger you are to prevent the very quick loss, you probably need a little bit more. That's why premature menopause, we give higher doses. But for the younger or the older women, they can get a lot of bang for their buck with a little bit. And I'll go even a step further. When we were at the Menopause Society conference, the lecture on bone health, was really great actually. And she made the argument that even women who already have an osteoporosis diagnosis, they're always told, well, estrogen's not approved for osteoporosis, only for the prevention. So now you just have to go for the bone specific.
But you have osteoporosis in only one bone, usually.
Yeah. So you can use
right? Like, what about your other 200 bones?
Yes, and you can use the full toolkit, right? You can talk about bone specific medications to, help with your osteoporosis, but it's crazy to say that we can't use estrogen to prevent one, further loss, and two, to shore up the bone health elsewhere, right? But again, because of this window, many of these women who are caught later with their osteoporosis and osteopenia are being denied this. And they come to be like, can I start it just for bone health alone?
Yep.
Well, I think this review of the data just really doubles down on that. The answer is absolutely yes.
Yeah, absolutely. And I mean, I've seen osteoporosis reverse. I've seen
Sure.
osteopenia reverse. Like, people think that once they have the diagnosis, it's fixed. It's not fixed. Our bones are growing and remodeling all the time. And I just want to get that into people's heads of like, your lifestyle matters. You know, I had this woman, she had osteoporosis, and I'm like, well, what do you do? You know, how are you moving your body? How are you blah? And she's like, ah. And I'm like, you understand, like, the bones respond, right? They're always responding to our environment. They're responding to weights. They're responding to, you know, bouncing and like all that stuff. And they respond to the hormones we put in them. It actually helps their mitochondria stabilize. So
Yes. And when we talk
people
about,
like they throw up their hands like, oh, osteoporosis. And I'm like, it can get better, you guys.
yes, and also, always thinking about this idea that some people will push back and say, no, 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 but you have to offer them bone specific medications. Yes, we agree.
Mhm.
Women should have the full toolkit. And part of, treating osteoporosis, and I'm not the bone expert, but is that we can offer them both things, and we have to calculate their risk of fracture. So at the Menopause Society meeting, they discussed this. So if you have a patient with newly diagnosed osteoporosis, but her overall fracture risk based on her T-score, her other risk factors is low, right? You can, in certain of these kind of, I'd say, more mild, less high fracture risk, start them on even estrogen alone,
Mhm.
or estrogen, and then work with the bone specialist to consider what bone specific meds may help lower your fracture risk. So we're not reductionist here. We're not saying only this and nothing else. It's the big picture, which often gets kind of lost in the shuffle.
Yeah, I mean, nobody has time for big picture in a 10-minute doctor's visit, right? Which is why podcasts are important. But I think the other thing people don't know about the bone-specific medications, once you already have the risk of osteoporosis, is the longer you're on them, the increased risk you have of atypical femur fracture. Like, these medications, number one, they're expensive. Number two, they have side effects. Number three, they've got their own fracture risk independent of osteoporosis once you've been on them for a while. And I think they actually talk about this in this paper of like, if we can kind of kick the can down the road so that you don't have to start those anti-resorptive meds until later, you won't have to be on them as long because they have their own set of risk factors.
Yeah, and I think this was a big part of their paper. They say, transdermal hormone therapy increases bone mineral density, reduces bone turnover, and in large observational studies reduces fracture risk. Denial of hormone therapy based solely on age or years since menopause might leave many women who cannot tolerate or access bone specific medications without effective therapy, right? So it's super important. I mean, the healthcare costs, the suffering, and the collateral damages of a fracture, ankle fracture, a hip fracture, any fracture is so debilitating on women, right?
Yep.
And I think that alone is a reason why women who are over the age of 60, they need to demand, or more than 10 years, need to demand how many women do you see? They don't even have a bone density done, Kelly. I mean,
know.
it's
I'm
atrocious.
ordering, as a urologist, I'm ordering more and more and more of them because I'm like, it's like taking your pulse. It's like taking the pulse of the bones, right? Get a baseline.
And the
And
stats are like horrifying. If we wait until the United USPSTF recommendations for the average risk woman, waiting till age 65 to start bone density testing, we're missing
it's
a
insane.
huge
1 in
group.
2 people will have a fracture in their life, and we don't even look at their bones until age 65.
It's crazy. So what I tell patients, they said, oh, but my insurance won't pay for it. I said, first of all, often the bone density testing, if you have to do cash pay, it's often not atrocious, number one,
It's
right?
way cheaper than a CAT scan or an MRI.
Yeah. Number
Way cheaper.
two, talk to your doctor about all risk factors, because if you can check one risk, which are
Yep.
many, you can, and if that's printed on your order for a bone density, you can often get it paid for, right? There's
Yeah.
like a lot of risk factors. So I think that's really important. So, yeah.
I think so. Do you know off the top of your head, is this an open access paper? Can
It's
people
an open access paper.
It is an
So,
open access
oh
paper.
no, I'm
Okay,
sorry, I checked. This is the biggest problem. It's
this
not
is
an
the
open
problem,
access
people.
paper.
This is why we have
So
podcasts. So this is not an open access paper, but I'll put the link in the show notes. Your doctor is able to pull it up because they have access to papers that are behind firewalls.
They just have to pay for it though. So like if you don't subscribe to the journal, it'll cost you $1.
But they'll get it through most doctors are affiliated with a hospital, and then they have access to their library. Yeah, so it's the Lancet.com Diabetes and Endocrinology 2024. So we'll put the link down below. But you can send your doctor this podcast.
Yes. And I screenshotted a number of the most important points, and it's in my feed. So you can kind of scroll in on the tiny print and read what you can. And, I think I'll do a few other follow-ups on this. But I think it's a really vital paper. And just to reference back to what was published last year, it was like 10 million Medicare, women who, Medicare recipients who were, who stayed on their hormone therapy.
That was a great paper.
That paper also kind of echoes, the same themes, that they basically showed that these older women who stayed on their hormone therapy or initiated it later really did really well on literally all fronts, right?
Yeah.
And so very reassuring. So this is kind of doubling down on that. So
I love it. And I want to give a shout out to the researchers and the physicians who actually freaking write these papers.
Yeah. Sasha Taylor and
thank you for doing that.
Did a good job at this.
We appreciate it. All right, my love, Dr. Corinne Menn, thank you for coming on and educating. We're clearly very passionate. Oh, one more thing, just for people who know. Do you have any patients over the age of 60 on hormone therapy that you've initiated?
Oh, like every day.
Yeah, me too. Because that's the number one thing I get on Instagram is it too late? I get it every day.
I initiated it myself after probably, if I had to calculate, I was 18 years hormone deprived. So
I do believe that Dr. Corinne Menn has lived like 4 different lives.
I might have.
I'm still learning about all of them. All right, very good. Thank you for joining us. We should do this more often. This is fun. I like talking about papers. People love it when we talk about papers. Let's do it more with papers and coffee. I love it. All right, till next time.